Welcome to this explainer. Today, we're building a massive bridge, a clinical to coding bridge to be exact. We're connecting the dots between clinical preventive care guidelines and strictly compliant outpatient documentation using those 2026 AHIMA and ACDS query standards. Look, as CDI specialists, medical coders, and educators, you already know that capturing a patient's complete health picture starts way before they actually get sick, right? It all kicks off with the adult preventive care visit. So let's jump right in and map out exactly how to capture these encounters accurately and compliantly. Here's our roadmap for this session. We'll quickly hit the foundations of adult preventive care, dive into gender-specific screening standards, and then cover preconception care guidelines. After that, we'll look at adult immunization schedules, outpatient risk adjustment HCCs, and wrap it all up with compliant CDI query standards. Let's get moving. All right, starting off with Section 1, Adult Preventative Care Foundations. So what's the real goal here? The absolute crucial takeaway is that these well visits are not about treating an acute illness. It's all about health promotion. It's proactive, risk-directed intervention for asymptomatic patients. When a provider does an adult well check, the documentation needs to show a full, comprehensive assessment of the patient's global functioning. It shouldn't just be a reaction to a single chief complaint. Now, to actually objectively capture a patient's lifestyle risks, we've got to rely on standardized tools. Think about it, using the 4-question CAGE questionnaire for alcohol use, or the DAST-10 tool for substance abuse. Instead of a vague little note saying, patient drinks occasionally, the chart really needs to show a specific CAGE score. And instead of just writing smoker, the provider should be documenting the exact pack year history. These objective, concrete details, they are literally the bedrock of high-quality clinical documentation. And here is a totally fascinating yet critical distinction for us. Preventative screening requires the absolute absence of symptoms, period. The U.S. Preventive Services Task Force actually bases its massive, highly influential screening guidelines on this exact premise. The moment a patient has symptoms, boom, we are no longer in the realm of routine screening.
That brings us to Section 2, Gender-Specific Screening Standards.
Okay, as CDI professionals, we absolutely have to differentiate in the chart between a routine screening encounter and a diagnostic workup driven by an active symptom. It's a game changer. If a woman comes in for a routine yearly mammogram, that's a screening. But if she presents with a newly discovered breast lump and then a mammogram is ordered, that's a diagnostic workup. The ICD-10 coding path changes completely based on how the provider documents the intent of that test. When we look at the USPSTF and specialty guidelines for women, the documentation has to go way beyond just jotting down that a mammogram or a DEXA bone density scan was ordered. It also has to capture if the patient actually refused a recommended screening and what education the provider gave them regarding that refusal. Similarly, for men and universal screenings, the clinical documentation really needs to reflect nuanced conversations. This is especially true for the shared decision-making required for prostate-specific antigen testing or PSA tests. Since the guidelines for men aged 55 to 69 rely heavily on weighing the risks versus the benefits, the medical record must explicitly capture that back-and-forth shared decision-making dialogue between the provider and the patient.
Moving right along to Section 3, Preconception Care Guidelines.
When evaluating a well woman visit for a reproductive aged female, documenting the optimization of chronic conditions, like, say, hypertension, isn't just good clinical care. It establishes a rock-solid baseline of medical complexity, and that is incredibly relevant for risk adjustment coding prior to pregnancy. Get this, did you know that nearly half of all pregnancies are unintended? Because of that staggering statistic, thoroughly charting family planning conversations is a massive clinical best practice. A simple, quick note saying birth control discussed just doesn't cut it anymore. Compliant documentation needs to detail the exact options discussed, the risk-benefit analysis provided, and the patient's ultimate reproductive life plan.
Let's jump to Section 4, Adult Immunization Schedules.
Maintaining the core CDC adult immunization schedule is essentially a mandatory checklist during outpatient preventive visits. Whether it's giving the Shingrix vaccine to an older adult or updating a Tdap booster, checking this schedule ensures that communicable disease prevention is actively managed and accurately documented. So, if you're ever auditing a chart, make sure that every single administered vaccine explicitly includes all these tracking details. Also, providing the Vaccine Information Statement, or VIS, is super critical. The charting must clearly reflect that the patient received this education and actually had the chance to ask questions about potential side effects. The whole shebang needs to be in there. Now, let's tie this to the coding side in Section 5, Outpatient Risk Adjustment HCCs. The major takeaway you need to grasp here is that capturing active chronic conditions to support hierarchical condition categories, HCCs, demands the exact same rigorous compliance in an outpatient setting as it does in a hospital. You simply cannot rely on leading EHR alerts or little software nudges to get a provider to click a diagnosis. The technology and the CDI pros behind it have to strictly adhere to non-leading practices. No exceptions. When providers meticulously document the chronic conditions they managed or optimized during a well visit, coders can then accurately apply HCCs that reflects the true clinical complexity of that patient panel. For instance, if a provider evaluates a patient's diabetes control specifically in the context of their cardiovascular risk during a preventive exam, that totally validates the active nature of that chronic disease for HCC capture. Let's bring it all home with Section 6, Compliant CDI Query Standards. Okay, to ensure your outpatient query templates never inadvertently lead the provider, you have to lay out the objective clinical facts. Think abnormal lab results or a high BMI calculation. Then you simply ask the provider for their clinical interpretation. A compliant query never, ever says something like, please document malnutrition to impact reimbursement. No way. It has to allow the provider to freely say, unable to determine, or to provide a totally alternate explanation. Now, you might be wondering, when should you query for prior encounters in an outpatient setting? This is a huge question for outpatient CDI specialists, right? Because we frequently rely on historical problem lists during these really short encounters. In a fast-paced ambulatory environment, leaning on past data is super common, but man, it is heavily regulated by the 2026 standards. So there's a really strict rule to remember here. You cannot query an old diagnosis just to get it on a claim. It must actively impact today's preventative care or management, period. If a patient had a condition, say, 5 years ago, and it requires zero monitoring, zero evaluation, and zero treatment during today's visit, you absolutely cannot compliantly issue a query just to drag it into the current encounter's problem list. You always want to anchor your queries directly to the objective findings. That means citing a high BMI, an abnormal C-gauge score, or a specific screening lab result to stay compliant. The query professional must never subjectively interpret these indicators. If the record shows a BMI of 41, you cite the BMI of 41 and ask for the associated diagnosis. You do not diagnose severe obesity on behalf of the physician right there in your query text. I'll leave you with this final thought to chew on as you audit your next chart. Are your clinical indicators truly telling the complete, compliant story of your patient's risk? It's like a giant puzzle, and every compliant detail matters. Please like, share, subscribe to Decode Healthcare with Harshal.